Perinatal loss is an area of our unit that some people may feel nervous about, may be uncomfortable about starting to do, but it is important work on our unit, and it is very rewarding work. You will find that our lost patients are some of the most grateful patients that we have. The most gifts and cards you will get are from your lost patients. So it can be very rewarding work, but the key factor here is that attention needs to be paid to self-care, self-assessment, self-reflection in order to continue doing this important work. We're going to discuss some theory. So what is grief? Grief is the psychological, behavioral, social, and physical response to a loss. It is a continuing process that changes over time. It is a natural human reaction. So all people will have this reaction with the exception of probably psychopaths. It can be any type of loss. It could be your dog died. It could be your house burnt down. What matters to you as the person is that it is recognized as something that you have lost. It does not need to be recognized by others. So if I don't like cats and your cat died, but yet you're grieving this loss, it doesn't matter that I don't think it's a loss to you. It is a loss to you if you perceive it that way. And so the type of loss, whether it's the loss of a person, a house, a marriage, it doesn't predict the way a person or a family is going to grieve. So we have to approach each person's grief as different and individualized and respect where they are in that grief process. So grief includes aspects such as physical, emotional, intellectual, spiritual, social, and occupational elements, is highly influenced by culture, religion, highly influenced according to gender, and slightly influenced by personality. It's so unique and different from person to person that you have to respect and allow everyone to grieve in their own way. And so mourning is the public or cultural display of grief. It's what's being shown on the outside. And it's only through mourning that grief can be resolved. So you have to go through the motions of mourning if you're ever going to come out of this loss on the other side and be able to manage and cope in the world. So as nurses, we have to allow, quote unquote, allow our patients and our families to grieve, because that is how they're going to get through this process of this major loss for them. And if they start mourning the loss here, it will help facilitate their grief and their mourning when they go home. So the goal of us as end-of-life care nurses is to help the family start a normal grief response. So there's 4 tasks of mourning for a person. They need to accept the reality of the loss. They need to process the pain of grief. They need to adjust to the world without the deceased, and also find an enduring connection with the deceased while moving forward with life. So that is one of our responsibilities as end-of-life nurses, is helping these families develop and maintain an enduring connection with the deceased, which is particularly difficult with perinatal loss because once the baby is born, they only have a short amount of time to be with that person and develop a bond and make memories with that person. It's different if you say you lost your grandma, for example, and you've had 30 or 40 years of memories and time spent with your grandma. These families don't have that. They only have a few hours to a few days to make memories. So that's why the memory making and the bonding as a family while they're here on our unit in our care is super important, and we have to facilitate that. So there's sort of 3 phases of grief and mourning. The first phase is avoidance or protest. So This could be on our assessment unit if the patient comes in not feeling any fetal movement and we've diagnosed an IUFD, an intrauterine fetal death. So the patient receives the news that there's no fetal heart, or the patient's in the doctor's office and has been told that there's a grim prognosis, or they're not able to find the fetal heart. The first phase is avoidance or protest. So this is when the family receives the news of the loss. It can last from a few hours to several days. The initial response is shock, confusion, denial. They may be avoiding making decisions, or they may protest the situation altogether. The point is they're not acknowledging this loss. They haven't fully absorbed what this loss means to them. And they may even try to reestablish the relationship. So what does this look like on our unit? It could be some people show anger or hostility, either towards themselves or directed to other people, such as the nursing staff. The patient may have lapses in memory. She may be anxious, restless, irritable, so physical irritability or emotional irritability, and she may have somatic distress, such as a headache or stomach upset or throwing up or maybe diarrhea. The body responds in that way. And so it could be something like she calls you back into the room and she's like, I just felt the baby move. I just felt the baby move. It's still moving in there. Well, there may not be a heartbeat and there may not be the fetus actively moving, but he could be shifting in utero because there's still fluid in there and it will shift in response to movement and gravity. So she may be perceiving that shifting in the fluid as fetal movements. She may ask for a second opinion, like, can I have another ultrasound? Can you please keep looking? And absolutely, we can keep looking. And then one of the major things that patients experience is, this can't be happening to me. This was not something as terrible as this can't happen to me. There are a lot of people in the community that think when it comes to having babies that you either have a 9-week miscarriage or you have a full-term healthy baby. And we know, working on this unit, that there's so much in between that could go wrong. We do have happiness on the unit, but we also have very, very sad on the unit. And so people in the community don't necessarily think that we lose as many babies as we do. They think that modern medicine is advanced and we don't have babies die anymore, but that isn't true. We do have very sad outcomes all the time, and we do have about 3 lost patients a week, and that's not counting all the babies that die in NICU, and there are actually quite a few babies that die in NICU or at home and then come back in, or they're readmitted to peds. Quite a lot of babies die in the first few months after birth that we don't even hear about. The next phase of grief is confrontation and disorganization. So this is when the patient, the family, realizes that the loss is happening. This is real. It is happening to me. So they've absorbed the meaning of the loss. It is the most intense and painful phase. Ideally, they are starting this phase of grief while they're in our care. It would not be a healthy sign of coping if they were still in phase 1 upon discharge. Most people get to this phase of realizing the loss and, intensely mourning and grieving. Most people do reach that phase while they're here. Some sooner than others, and the patient and the family grieve differently as well. So the patient and the family is gradually absorbing the meaning of the loss. They may be preoccupied with thoughts of the deceased. So she may be rubbing her belly, touching her belly, looking at her ultrasound pictures. And she's also trying to relive the relationship. So again, this is different with a baby that's died in utero, that has never lived on the outside, that the family has never held in their arms. Different from losing grandma, because you had a lot of time with grandma. You have photos, you have memories, you have maybe a blanket that she made you, you have the cookie recipe that grandma gave you, you have the rocking chair that grandma gave you. So you are able to relive the relationship with grandma or with an adult. You're able to relive that relationship differently than with a fetus, an intrauterine fetal death, a person that has never lived on the outside. It is much more difficult to relive the relationship with someone who has never really been here. So that's why, again, our job as nurses performing end-of-life care is to help them make memories and help them start a normal grief reaction. Also to make memories and give them tangible mementos to take home so that they are able to relive the relationship at home once they leave our care. And so this phase, confrontation and disorganization, is characterized by inconsolable sadness, loneliness. They may feel guilty about losing the baby. Anger can always show up and replace other emotions such as sadness, disappointment. And then there also may be hopelessness. So the third phase of grief and mourning is accommodation and reorganization. So our patients only staying with us for a few days at most don't get to this phase, specifically with perinatal loss, because losing a baby the grief process is way longer. But what this would look like at home is there would be a decrease in the symptoms of acute grief. They would gradually and cautiously reinvest in the world socially and emotionally. They find a way to live with the death. They might be looking forward to the future. So on average, the average loss of an adult person, this phase of accommodation and reorganization might take 1 to 2 years. But with perinatal loss, losing a baby, it can take up to 5 years. So when you have such a significant loss like this in your life, it changes the way you view life. It changes the way you view your relationships, the way you think of others, the way you think of the world around you, your vision of the future. And there generally isn't a return to one's old self. And this is especially the case with perinatal loss or losing a baby, is that you will find people around the patient and family say they never really went back to their old self. So let's talk about trauma for a little bit. What is the definition of trauma? It is something that happens to a person that is sudden, unexpected, they didn't see it coming, they have no control over it, and it is intensely emotional and assaults maybe their physical state, their emotional state, their mental state, and they are profoundly affected by this. So the key points here is they didn't see it coming and they have no control over it. And this is the case in a lot of our lost families where they're going along in their pregnancy, they're happy, they're planning for their baby, and then all of a sudden they're told that all of that is over. Losing a baby and losing a pregnancy is absolutely considered a trauma. And you will find, although we don't see our patients in the community and we never get to see them go home and find out how they're doing, you will find that many of our patients end up with PTSD and have significant mental health problems, including depression and anxiety after they lose this baby, after they leave our care. So what's different or what's unique about losing a pregnancy or losing a baby that's still in utero or shortly after death versus losing an adult or an elderly person? The grieving is more intense, it's more complicated, it's longer lasting, more difficult. Again, the trauma of it, it's sudden, they have no anticipation of it. There can be major fluctuations in grief over time. And so things that will trigger the grief again will be coming back into this hospital, can be very difficult for our patients. the date of the loss, the date that the baby was supposed to be due, the birth date, all those days can be re-triggering for the patient and family, as well as watching other people go on to have normal, healthy babies around them. The other thing I've mentioned a couple times is that with the loss of a pregnancy or a newborn baby, there are not as many physical, concrete objects of the deceased. There aren't as many tangible things that they've left behind that we can cherish and treasure and hold close to us. Remembering and re-experiencing the deceased is more difficult because they were only here for such a short time, and because we don't have many memories, not many memories, but many tangible things to cherish. The other thing about losing a pregnancy or losing a newborn baby is that it involves the majority of the grief that is felt is the grief of the symbolic. And what we mean by this is they've lost something they never really had, which is very difficult to process. The longer you were pregnant, the longer the gestation, the more significant your grief. If you have no other babies at home, your grief is more pronounced. It's less pronounced if you do have other children at home, and that just makes sense. The process of grief and going through the 3 phases of grief can take anywhere from 2 to 5 years. More difficulty investing in a similar relationship, so a lot of anxiety trying to get pregnant again or going through another pregnancy after you've lost a baby. The woman, the patient who has been pregnant, it will be a profound damage to their self-worth. They may feel shame, humiliation, and guilt that their body has failed them or they're unable to produce a healthy baby. There's something about giving birth that makes us feel like we've completed the circle of life and that we're whole as a person that can give birth. And so when you're not able to produce a healthy baby, it can have profound damage to your self-worth. So back to this idea of grieving the symbolic. So the physical loss would be you've lost the actual baby, you've lost the belly. Pregnant people get a lot of attention when their bellies are growing. People want to touch their belly. They want to feel the baby move. The patient has felt the baby move. Sometimes there's milk coming in, which could add additional grief to the situation. And so the physical loss is what is acknowledged by others, but what the patient and her partner and family are grieving in their hearts and their minds that nobody sees and nobody knows about is the symbolic, the loss of hopes and dreams in the future. So, people, when they find out they're pregnant and they get a positive pregnancy test at home, in an instant, when they find out they're pregnant, they instantly bond with that baby. And that bonding and that dreaming and that thinking about the future, thinking about their birth, planning the nursery, that goes on in their minds almost continuously for weeks and weeks and weeks. If you think about a 10-week loss, they've had 10 weeks to dream about this baby and make hopes and have plans and dreams for their baby in the future. So they're fantasizing about the child to be, maybe birthday parties, maybe graduation. And so that's all taking place inside them that is invisible to everybody else, that nobody sees, but it actually represents the majority of the grief that is felt by the patient and their partner. And it really isn't acknowledged by any of their other family members because it's not seen. We don't know what's happening inside them, but it absolutely is happening inside them. So traditional gender roles of men and women and mothers and fathers, you will note differences in the way they grieve. It's called incongruent grieving. So men are fathers, generally speaking. Not everyone is going to fit this description, but in general, you will find that the fathers of the baby, their grief is shorter, less intense, less guilt laden. They don't feel guilty that they've lost the pregnancy because they're not the ones that have lost the pregnancy. In general, men's pain, frustration, and disappointment is more likely to be displayed at anger, and it may bubble up to the surface with frustration about one of our processes, like let's say parking, or when their meal trays are coming, they might be grieving, might have pain and disappointment in their hearts, but externally, it's going to show up as anger. And if it's just one more stressful thing to have to worry about parking, that may be what they choose to get frustrated or angry about, and it may be directed at you. Just know that it's not personal. Don't take things personally here. It is just the way that their grief is presenting for them. Also, in general, men may be ready to move on sooner than the person who has given birth to the baby. They might believe they have to stay strong for the other parent, so they may not show a bunch of feeling externally. There's also a lack of social support for grieving fathers. Do they have benefits? Do they have sick time they could take? Do they have grieving time they could take, or bereavement leave? In general, men have more difficulty expressing and coping with feelings. The men or the partner who has not given birth may have to deal with logistical issues such as childcare for other children, or planning a funeral, or having to organize getting the baby buried in the method of their choice. So they're dealing with logistical issues because the birth person has given birth and they are recovering from childbirth. So they may push down their grief, push down their mourning in order to deal with these logistical issues, and then they may be experiencing their grief at home, or they may be waiting for a private moment alone to display their grief and their sadness in private, not in front of other people. In general, the mother or the person who has given birth, she experiences the pregnancy and the fetus inside her as a part of herself. There's feelings of powerfulness, there's feelings of empowerment when you're pregnant, when you have a baby. You feel special, you get more attention, you feel like a person that has completed the circle of life, or femininity for traditional gender roles. But when you lose a pregnancy, when things go wrong with the baby, you feel like you've lost control over your body, and you feel like you have failed or you're broken because you have not been able to deliver a healthy baby. And then you take all of that guilt, all of that pain, sadness, and compound it with the pain and the physical demands of labor and childbirth. You end up with a patient who is extremely distressed in labor and delivery, but I believe that it's the emotional pain as well as the physical pain that are making her symptoms so pronounced. It can be quite significant distress that you observe from the birthing person. Siblings. So if there's siblings involved, the family can choose to bring the siblings in to see the baby, hold the baby, touch the baby, make memories. That's totally their choice. The siblings usually are profoundly affected with the loss of this baby because they actually go through two losses. They lose the sibling itself and the baby, but then they also lose their parents the way they used to be and the way they used to know them, because when you lose a baby, research has shown that you generally never go back to the way you used to be. You're usually permanently affected. So they've lost two things, and then have to deal with the ongoing grief of the parents at home when they maybe just want to get on with their normal life and just be a kid again. And so it's totally the family's choice if they want to involve their siblings in the memory making and photos and legacy building. That's totally up to the family, and it would be age appropriate as the family sees fit. So what are the rights of a parent when a baby dies? So one thing we need to do for these families is acknowledge their baby as a member of their family who is absolutely not replaceable. We may be thinking on the inside that, oh, they can always have another baby, oh, they have 5 kids at home. But to this family, this was their baby, they loved their baby, they wanted their baby, and he is an irreplaceable member of their family. They should be given every opportunity to see, hold, touch, and love their baby for as long as they want. We don't put any time restrictions on this. They have a right to have photos and memories made. So we are going to take family photos. We are going to bath the baby, dress the baby, and give them blankets and toques and other items to take home. And while we're giving them all these things, we're also making memories. So maybe the family takes some video on their phones. I mean, technology has changed what this looks like on our unit because most people have smartphones and most people take their own photos and their own videos. That's absolutely okay. But we also do have a camera and a photo printer to give them photos if they don't take their own. Other memory things that we give them, for most patients, we give them a wooden box to put all their mementos in. We give them a card that's got the date, time, length, and weight of their baby. We do handprints and footprints. And if the baby has hair, we could even cut a lock of hair off the baby and put it in a little plastic bag for them. So I'm showing you these pictures. They're obviously very old, 1800s. These are pictures of deceased babies, and it might seem odd and strange and uncomfortable to you that the family is loving on this deceased body as much as they are, that the family is taking photos of this deceased baby, but this is just to let you know, across cultures and across the span of history, taking photos of the deceased and loving on a deceased body is normal across many different cultures. Cultural displays are different, but there are basically 2 main events in life across all cultures, across time. It's birth and death. And both birth and death need to be acknowledged, and both birth and death have ceremony and ritual and observances that go along with the birth and death that we need to help facilitate for these families. Other rights of the parent to name their child and bond with him or her. It would be a concerning sign if they did not want to name the baby. That would indicate perhaps that they haven't accepted the reality of the loss. They have the right to observe cultural and religious practices. Cultural and religious practices are very, very important parts of people's life and lifestyle, and we need to help facilitate these practices whenever possible. They deserve to be cared for by an empathetic staff who respect their feelings, thoughts, beliefs, and individual requests. This is particularly important when we are talking about a family that has elected to terminate their pregnancy. They're still worthy and deserving of our respect and caring, even if we don't agree with their choices. They have the right to be with each other throughout the hospitalization. So again, with the open family presence visiting policy, this has changed what this looks like, but we would put no time restrictions on visitors. We would put no limitation of visitors. They can have as many family and as many people up here as they want, again, because they only have a short amount of time to be with this lost baby. And also they deserve to have time alone with the baby, allowing for any private or personal things that they want to feel, say, do. So we are going to be present for our patients as much as possible, but we also can excuse ourselves and give them some alone time as we feel is appropriate. They also have the right to be informed about the grieving process, and they do have the right to request an autopsy or any other type of investigations that we have available to try and find out why, the cause of this loss. They have the right to have information presented to them in an understandable language, and this is particularly important with people who are English is not their first language. I think in the English language and in our culture, we tend to use a lot of slang, a lot of sayings that maybe people wouldn't understand. Like an example of this would be, oh, the grass is always greener on the other side. Somebody whose language, English, isn't their first language might not know what that means. And so we need to be careful with our language and be as direct and concrete as possible, but not using overly medical jargon. The family deserves to have knowledge about the baby's status. Let's say we were terminating a pregnancy and the patient wanted to know if the baby was still alive or deceased. We don't typically do fetal monitoring in labor, but maybe we do a fetal heart just to give that family information that yes, their baby is either still alive or their baby has passed. They deserve to know as much as possible about what caused this death, which includes autopsy, blood work, imaging, and any pathology reports, such as what the placenta looked like upon delivery. Can potentially tell us a lot about why this baby passed away. Again, going back to cultural and different countries of origin, different ethnic traditions, most cultures have a farewell ritual or a burial or a cremation or a funeral is expected and customary for most people, wish to have that for their baby. So we try and accommodate that whenever possible, but it does need to comply with local, provincial regulations, such as you have to bury a body in a registered cemetery. You can't just bury the body anywhere, like in your backyard, for example. We have to comply with provincial law and regulations, but as much as possible, facilitate their own traditions. And then we are going to provide them with information on community supports that are available to them once they leave our care. So what are the rights of the baby? The important thing to keep in mind as end-of-life care nurses is the baby is our patient as well. And it doesn't matter how small the gestation, they are a human life, and human life is sacred, and we need to treat the baby with respect and dignity and acknowledge this baby as a person who was born and did live and then died. He deserves to have a name. He deserves to be seen, held, touched, and loved, not only by the family, but by us as well. One of the things that we get feedback from our perinatal loss committee is we have community family liaisons on that committee. One of the things they've told us is that they're very sad that the nurses and the doctors don't love on and cuddle and give as much attention to the lost babies as the live babies. So it makes these families feel less than. And so one of the things we need to do with these babies, although it may seem odd and possibly uncomfortable, is we need to touch, hold, talk to the baby and love on this baby as much as all the other babies on the unit. It is extremely comforting to the families to see the nurses care about their baby as much as we care about them and everyone else on the unit. They deserve to have their end of life acknowledged, and they deserve to be put to rest with dignity. So what are our responsibilities as nurses? It's been proven that the care that a family receives before, during, and after their loss and throughout their hospital stay can have a profound effect on their memory and outlook of this time in their lives, but it also does affect the grieving process. So our job is to help them start a normal grief reaction, and our behaviors need to be non-judgmental about their choices. We need to convey a deep sense of caring and really connect with them as a human being, not just as a nurse-patient relationship, but get personally involved and sit with them through their normal human emotions of sadness and grief. So the first thing that you need to do when you go into a patient room and you're meeting your patient for the first time is you need to go in and don't stand over top of the patient. That's very, gives you a feeling of power over the patient, and we absolutely don't want that. So you're gonna sit on a chair, wheel your chair right up to the bed. You're gonna get right down nice and low on her level, and you're gonna look her in the eye, and you're gonna hold her hand, and you say, "I am so sorry for your loss." That's all you need to say. You don't need to say anything else. And then you just sit in silence and you allow the family to absorb your condolences and acknowledging the grief, the loss right off the top of your therapeutic relationship will start you off on the right path of forming a therapeutic relationship with this patient. Again, we're going to create opportunities for bonding and memory making. We're going to help them cherish their baby and preserve their memory with handprints, footprints, photos, dressing the baby, whatever the family wants, maybe reading the baby a story. And then we do want to meet the particular cultural or religious needs of the family. So before the baby's born, it's helpful to give the family at least some idea of what the baby may look like. We know that a 16-weeker or 14-weeker may be smaller than our hand. You know, a 24-weeker, 22-weeker would be about the size of our hand and would have their head about the size of a pool ball. You know, if the baby is missing a finger or missing an ear or, you know, maybe doesn't have a fully developed brain, we can tell the family what we know about this baby from the ultrasound report. So giving them as much information as possible so that we can prepare them for what this baby might look like. We can talk about what they want once the baby is born. Do they want to not see the baby at all and we can take the baby out of the room? Do they want skin to skin? We offer them the same options that we would offer every other family. So we offer them the opportunity to put baby skin to skin and for that baby to stay there as long as the parents want. You need to judge the situation as far as the funeral, arranging a funeral and doing the paperwork. Some people, it's not appropriate to start talking about paperwork before the birth because they have just discovered this loss, so they haven't fully absorbed the meaning of the loss. But if they're asking about paperwork, if they're showing an interest in discussing some of the paperwork, you can absolutely get that started. Talking about what their options are for burial. And then helping the parents with sibling involvement as appropriate and as much as they want their other children to be involved. So this is a situation that was out of their control and they didn't see it coming. So one of the things that we can give back to these parents is to give them choices in a situation that remains mostly out of their control. So we give them what choices we can in order for them to feel empowered about their experience so that it doesn't feel like it's so much out of control for them and so much of a crisis. So we give them gentle guidance in making decisions about end-of-life care, but keeping in mind they may be in shock, they may be sleep deprived, they might not be processing this information. You may have to repeat them yourself. They might be forgetful. That's okay. We keep repeating the options that are available to them. We may write down things for them to review at a later time. We give them the handouts, we provide them with lists, and then we also give them time to make decisions and not rush these decisions. They are very important decisions for how they are going to investigate the loss or put the baby to rest permanently. These are very big choices for a lot of people. One of the most helpful things that you can do is do less talking and more listening. You don't have to say a lot. Your presence is your gift in this situation. You are sitting and holding space with this family, and that is more therapeutic to them than you constantly talking and not really saying anything of any importance. Just because you feel like you have to fill the space, silence is okay. You're going to be present in the room as much as possible. It can be uncomfortable when you're first starting to work with these families, but we want to feel like we want them to feel like they're well taken care of. We don't want them to feel like we're avoiding them. Sit and be present with the family. Give them time to tell their story. It might be very beneficial to them to have them tell you their story from the beginning, or to have them talk about their baby and the things that they've learned about their baby once they've met them and had some time to spend with them. So we are there to provide emotional support. This includes no judgmental statements, no talking down to them, not being condescending. We don't want to correct them in a way that makes them think that we think they're better than them. But if there are factual misconceptions and they're not understanding something technical or medical, we do want to try and gently correct those. We don't want to assume something about the situation if we're not we don't want to make assumptions about the situation or assume they're feeling a certain way when maybe they're not. We need to remain calm and gentle when they're expressing strong feelings. And again, just it takes practice to get comfortable with strong feelings, crying, sobbing, wailing, but it will get easier with time. And just compassion and kindness and letting them know that you're there for them, whatever they may need. We need to be careful with our words when we're looking after these families, because they are very sensitive and they are in a very vulnerable state. So it's what we say, which would be our words and our verbal communication, but it's also how it is said. That would be the non-verbal, including our body language and our tone. We want to take into consideration the environment, what other people are around, what time of day it is, maybe cultural factors such as whether her head is covered with a scarf or not, or whether she wants her head covered with a scarf maybe before a man enters the room. Really think about what you're saying and the way you're saying it, so that we don't end up being hurtful or hurting our families by something that we've said. So in our perinatal loss binders, we have 2 of them on the unit. There is a list of examples of what to say on the left, but more importantly, the things on the right should never be said, never be implied, because they can be extremely hurtful. Something like, it wasn't meant to be, everything happens for a reason. Saying those things, or, oh, you can always have more babies, Those are not helpful. They are extremely hurtful. And again, that goes back to this baby. They wanted this baby. They loved this baby. They were planning for this baby. It is an irreplaceable member of their family. What can we do? We can listen more than we talk. Be honest about the situation. So answer questions honestly. And if you don't know, just say you don't know and that you can go and find the answer somewhere. Please don't act like you're grossed out or repulsed by the baby. Be comfortable touching a lost baby. So this just takes time and practice and desensitization. Treat the baby as a special treasure, just like you would treat any other live baby as a special treasure. Do what you say you're going to do. If you said you were going to call the doctor, if you said you were going to call the priest in, make sure you do those things and follow up. Things not to do is minimize the loss. Don't avoid the family. Be present as much as possible. Don't take their anger personally. It's not about you. It really has nothing to do with you. You are just there to help them. It is probably the way they're expressing anger and the way they're expressing the totality of the situation that we're in. Don't ignore other family members, such as siblings or grandparents. Don't avoid questions. Don't give advice, because this is not you in this situation, and you can say you know what you would do, but until you are actually in that situation, you really cannot speak as to what you would do if you were them. And try not to use medical jargon such as fetus, products of conception, things like that. Even though this is an overwhelmingly negative experience, we do want to try and make the experience as positive as possible. So smile, make little jokes, enjoy yourself as you're washing the baby, dressing the baby. Encourage the family to be involved in touch and caring for the baby as much as possible. They really like it when we discuss the features of the baby. Oh, like, look at his little nose. Oh, he looks just like his dad. He's so cute. What a perfectly beautiful mouth. Oh, he's so beautiful. They really like that. And it really conveys to them that we value and love their baby as much as we value and love all the other babies. Again, facilitate attachment and bonding. So talk to the baby, call him by his name, so he has an identity, so he is one of our patients, just like everybody else on the unit. Helps to form an identity. Visiting policies around the clock, and then whatever items that they want to bring in from home and use for their baby, like a moss bag, for example, or a christening gown, absolutely they can bring in and use whatever they want. Let's talk about termination of pregnancy. So it is legal in this country and in this province to terminate a pregnancy up to, I think it's up to 24 weeks. It is legal in other provinces such as Alberta to electively terminate pregnancies at greater gestation, but what you need to realize is that while it is legal in this province and this country, it will be a service that we offer and provide to all of our patients, regardless of your personal beliefs or anybody else's personal beliefs. We do the majority of our terminations for what we call a lethal anomaly. So something like the baby's developing with part of his brain missing, the baby has a diaphragmatic hernia, the baby has a 2-chamber heart, no lungs, no kidneys. These are conditions that are not survivable after death. The baby is only alive in utero because the birth parent carrying the pregnancy is keeping the baby alive, and these babies will not survive after birth. So when that kind of a diagnosis is made with ultrasound, the family is offered a termination, and they can either accept or decline. And we care for all these patients because it is healthcare, it is their right and we offer this service because it is part of healthcare. And so our patients are admitted and we care for these patients like any other patient on our unit. They deserve our respect, they deserve our kindness, our caring, compassion, and we do treat it like a loss because it is a loss to them, even though you might be thinking, oh, they're terminating this pregnancy, they didn't want this baby. They absolutely wanted this baby. They wanted a normal, healthy baby, and this is not something that is going to give them a normal, healthy baby. So their decision to end the pregnancy and perhaps try again to have another baby in the future, that is totally their option. So these patients and families, more than anyone else on our unit, are deserving of our respect and non-judgment. But if you feel like morally, ethically, spiritually, you are not able to give these families the very best care that you can, then according to the Code of Ethics for Registered Nurses, the Canadian Nurses Association, you can, once, if the patient is out of danger and is safe, you can step back and request to not be placed with this patient. Because if you can't give her and the family the best care, then we want to give the family the best care and give them a nurse that can provide that care to them. So you can have a private conversation with the charge nurse. You can have a conversation with management to be reassigned once the patient is stable and out of danger. Why do people terminate a pregnancy? So I talked about undeveloped lungs, kidneys, maybe severe cardiac anomalies. There are a lot of other genetic syndromes as well that are not compatible with life. And if a genetic diagnosis is made, then the family is offered a termination. So why do people terminate pregnancies? It could be a personal reason. The pregnancy was unwanted. Usually if it's personal reasons, those terminations are usually done earlier gestations over at Saskatoon City Hospital and Women's Health. For most people, the reason they are terminating is for a medical problem with the baby or a significant medical problem with mom, where continuing the pregnancy would be putting her life in danger. Majority of the situations you will encounter on our unit is termination for a medical problem with the fetus. So here's just some examples of statements from real patients for why they would terminate the pregnancy. We didn't want the baby to suffer. We wouldn't be able to manage with a sick child in NICU. Some of these cardiac conditions would require like several surgeries, several trips to Edmonton that maybe the family couldn't handle at that time. Challenges of raising a special needs child, and maybe just the desire to end the pregnancy as soon as possible so that they can move on from it. And those are all acceptable reasons. On the other side of this spectrum of care are patients who are admitted to our unit and are given a very poor prognosis that their baby will not survive, but they choose to continue the pregnancy anyway. And so we may feel like this situation is hopeless, that there's no chance of this baby surviving, but it is their choice to continue the pregnancy just as much as it is their choice to terminate the pregnancy. And we need to support these patients as well. Some of the things that they've said are they were hoping for a miracle. They were hoping the tests were wrong. They could accept a less than perfect baby. They felt that possibly a miracle could happen. And we have had miracles happen on this unit. And so we support the patient where she's at and don't make assumptions or judgments about her choices. I'll just touch again on mental health challenges after discharge. What can we do about these as nurses on our unit? Again, this is a traumatic event, and many of our patients have PTSD afterwards. Care, compassion, non-judgment, keeping the room as calm and quiet as possible, and just your discharge teaching should include a conversation about postpartum depression, but also what is the difference between postpartum depression and grief. The patient might have both. Having a conversation with the patient's support person about what this might look like in the person, like she can't get out of bed for a week, she's not eating, she hasn't showered in a month, and when to seek help and where to go if they need help. Our prenatal home care nurses do follow these patients in the community. It starts with a phone call, and it may progress to a home visit if the nurses assess that the patient would benefit from a home visit. And when you're sick, you don't know you're sick. So the person that's going to identify this is probably the support person or other family members. And those people need to encourage the patient to seek help if help is needed. We do have several resources for loss. Chapter 11 of the NRP textbook talks about ethics and care at the end of life. It's really good if you want to review that. There is a chapter from the Public Health Agency of Canada on loss and grief, and there are 2 to 3 chapters of Moral B that deal with loss as well.